talk about something. This is something we've been dialoguing and discussing for quite some time, and there's nothing that's official, but this is sort of a hypothetical lecture that we want to throw out. We've been dialoguing about this with sort of the community, and I think what you're going to learn about as you get to be part of this community. What community am I talking about? I'm talking about ophthalmologists who are focused on taking care of blind, poor patients. And you recognize that it's actually a fairly small community. And I'm not just talking about American doctors. I'm talking about Indian doctors. I'm talking about Honduran doctors. We're talking about Guatemalan, Ecuadorian doctors, Brazilian doctors. There's a subgroup of ophthalmologists that are dedicated during their career. And then there's another subgroup that at age 55 they say, you know what, I want to give back. And so we're in a particularly neat career specialty that we all know how big of a difference you can make. And so it's interesting to me to see, you see young guys like John Cropsey who knew from the beginning that this is what he wanted to do. And then you see others, and I interact with quite a few surgeons who, right as they retire, they decide this is what I want to do. And then others that are mid-career and others that are interspersing. And so obviously we have a different age group around here that we're all exploring this. But I just want you to say this is a community that is, it's fairly defined. It seems like we know the names, and the community's gotten stronger. I think David Chang has done a great thing for this community, and Jeff Tabin and Sandik Ruat, and there's a lot of interaction between the different techniques of Erevin technique and the fishhook and the Blumenthal method and the doctors who do these things. So anyhow, as we at Vision Outreach and Global Sight focus on, how can we improve our training experience? Part of the question that we're running is are we ready for certification? That seems kind of scary. We don't want more things we have to certify. I mean, I hate going through my board certification process every 10 years. I'm not grandfathered in, nor are most of us. So I'm not suggesting that, so you can be relieved from the start. But as we think about learning MSICS, we recognize that there's really three subgroups of people who are learning. There's the US and European or Western trained phacosurgeons, those that are fairly early, less than 1,000 cases under their belt, and those that have done 1,000 or more. This is somewhat arbitrary, but I'm just putting this is one level of people who are learning. A second is an ophthalmology resident, whether that be a US resident or an English resident or a German resident or even a Nepalese resident or an Indian resident. And then nationally trained ophthalmologists around the developing world. And probably the biggest thing we know with nationally trained ophthalmologists is it's quite variable how much surgery you have under your belt. So you could be a full ophthalmologist in practice for quite a while and you really don't have a lot of surgery under your belt. So anyhow, those are one way that I just sort of looked and said, well, if you're training someone, depending on their experience, you need to know that as a trainer. And if you're that person, you need to think about that as this is what I'm bringing to the table. And we need to be honest with ourselves in that. So how do we learn this? Well, you've heard of people saying, hey, I'll learn on YouTube. We actually have probably one of the largest collections on Global Sight Alliance of MSICS videos. And we started collecting MSICS videos 10 years ago before this was even sexy, and YouTube was full of them. What I don't like particularly about YouTube is that you can be watching, sort of mediocre. We want you to watch the best. We want you to watch, the variations on the best of the themes. So that would be my goal for that. Learning during residency, pretty tough in the US. I mean, how many professors know this technique? So learning during residency, if you're at Erevin, you're probably going to learn it, and certain residencies. So and then reading manuals, going to India to learn, that's sort of the classic way. I mean, there's Indian doctors, because this is sort of in their frame of reference. They're doing MSICS. This is what they're batting all the day. So they're glad to have U.S. doctors come over and you can do a lot of cases. And of course, we have the most famous doctor right here, Dr. Diego Mejia, who's one-on-one training in this hemisphere. I mean, you don't have to go to India to experience this. And so this was really built for busy phacosurgeons that don't have time to go to India. So historically, cataract surgery is obviously quite different. We're talking about scleral surgery. All the surgeons knew sclera, and now we look at the paradigm shifting. It's really changes. We use rigid IOLs. I mean, look at a little bit harder to put that flexible lens in, and Alcon's not even making rigid lenses anymore. And we had to do ECCE prior to learning phaco. I had to do that. So get your phones out, we're ready for the first poll. And the question is, go to the website if you're having any trouble texting, because the website works quite well. But were you required to do ECCE prior to performing phaco in your training? That's the question. So interesting, about 50-50, and we have a fairly young group of surgeons, so that's sort of good. But anyhow, so obviously some were, and I don't have extensive questions about how many did you have to do, 1 or 10 or 20. I think we had to do about 12, and that was 20 years ago. So anyhow, but that's obviously a paradigm thing for us as Western surgeons, is that we really, unless you're a trabecular surgeon, doing trabs and things, your scleral experience is lower. So what are the challenges with learning MSICS? We've obviously gone over a lot of this, but the clear cornea, the femto, the large incisional dynamics, we talked about just the fact that this is prolapse and delivery. But here are the other things we haven't talked about. The inferior viscoelastic that you might find in a place where you're not used to this great viscoat stuff that Alcon makes, or Provisc, or whatever US viscoelastic that's quite expensive and you can't have as much as you want. John, how many viscoats do you have over in Burundi? One, and it's guarded. It's under lock and key, right, for that case that you need it. So viscoat is awesome, but it's not what you get. What about when you get there and there's a different microscope and you're not used to that, or different instruments that may not be as good? You don't have the comforts. Nobody's pampering you. You have to set up things you're not used to setting up, and you don't have your favorite scrub nurse. You may have a high school student. You may have somebody who you're training to scrub, and how many scrubs have you really trained in the US? And mainly we have now flexible injectable IOL experience. So we're really even not used to hard, rigid lenses. And we do few M6 cases. Even if you're skilled, Steve still doesn't do hundreds of cases of M6 in the US. And really, truthfully, we have few dense cataracts. We have those lens blemishes, remember, what we take care of in the US. I'm being, if you're watching live stream, I'm not being totally serious. I want to make sure you understand. We take out real cataracts, and we do like 66984. So, all right. Few professors who have M6 skills is also the challenge. So if you look at residencies, how many residencies really have someone that's training them? And how many have somebody at the level of Glenn? That's a question. So, and then if you do learn MSICS, you're only doing it once a year or whatnot. So here's the reality. Here's why we're discussing this. So we deal with this quite a bit as we interact with surgeons who are coming to us, hey, we want to learn. So here's our 59-year-old confident, competent surgeon who does 25 to 30 in a day, and he's done over 15,000 phacos in New York where he lives. And he performs a 7-minute phaco with a very small incision, nuclear cracking, and he's interested in getting involved in missions. He has not been involved, but he says, I really would like to get involved. So he says he went to Ecuador. He went to Guayaquil, and he was there, and his paradigm was shifted because he was there with his phaco machine, or the phaco machine there, and he went, I can't do phaco on these cases. And it's not safe to do phaco, and I'm going to ruin corneas. And so actually that was when I got called or emailed or whatnot, and we said, well, look, here's what you really, he already knew the answer. I needed to learn M6. So he had done 20 ECCs in his early training at New York on an ear, and he studied the videos. He did the objective stuff, and then he says, I got to do Camp Diego. So he goes down and does the Camp Diego. He did 10 M6 cases with Diego right at his side, and he says, I'm ready. And I'm going back to Ecuador a year later. And so he did. And I was in touch with him, and I said, so how did you do? And it was quite interesting as this is a very competent surgeon, better than I am, probably in phaco. He's a phenomenal surgeon, but very humble and very conscientious. And he said, I lost vitreous in 30%. I had to put AC lenses. And he really felt, discouraged, and he felt, he let himself down. And so what he did is he said, you know, he knew there was a Cuban doctor who could do MSICS. He turned over the microscope to the Cuban doctor, and he went on and did the phaco on the less dense cases, and said, and I wasn't sure whether he was going to re-enter. But the truth is, this situation has happened with other doctors as well. And it, like I said, it's a bit astounding. That's why I said before, is why is it such a hard curve, and what is it? But there is a curve here to the learning. And the other paradigm that I want to just mention, as we know, missions are changing. We are not the only people that can do cataract surgery, and there are many other ophthalmologists in the world. I mean, here he's relying on a Cuban ophthalmologist because he has expertise. There are more regulations. Nobody can just slip in. So this is talking about certification. You know, do we need to have some level of, and agencies are more aware, saying, you know, what are your skill set? We want to do, we don't want to hurt patients, and we want people to be successful. And you can't rely on your U.S. training degree just as your ticket to come into any country and operate. So what's the goals of thinking through this? Really, we want to expedite training. We want to have less complications. We really want to set realistic goals. That's probably the primary purpose of thinking through some system of having a classification, of setting realistic goals so people have a paradigm. Because our paradigm of, I'm a great phacosurgeon, you know, a lot of us have egos that are here, and some have egos that are here. But if you're successful, you know, I know what I'm doing here. I mean, I've been doing this 20, 30 years. But we want to avoid the well-meaning doctor in an uncomfortable surgical situation, and we want to improve patient outcomes ultimately. So that's really what's underneath this. And what's been done, the ICO, which is the International Council of Ophthalmology, has an ASCR, which is the rubric, the surgical competency assessment rubric, and they have one for MSICS. It's a big chart, 19 different rubrics for assessing these SICS, as they call them, trainees, novice, beginner, advanced, and competent. And they go over everything. I mean, how well does the guy drape? How do they do for scleral cautery? The tunnel, the entry, you know, you can see every step of the surgery. You're graded by your trainer on how you did. And the black one are the steps, and the blue ones are global. You know, how did they do for eye positioning, you know, iris protection, overall tissue handling, how is this doctor doing? And so this has been developed as a way to assess the level of somebody. Are you a novice? Are you, what do they have? Novice, beginner, advanced beginner, and competent. The perceived need is that we really do need some way for us to classify ourselves to have a paradigm. Really, the paradigm, when it comes down to it, is for this surgeon who has done thousands of phaco, and he's worked with Camp Diego, to recognize he's still a beginner. He's not really ready to be on his own, even though he says, well, I've done all those things. So that's part of what it is helpful to the mission agencies and the clinics and the hospitals to understand where people are at. We want to put people in the right situation. Obviously, we don't want to discourage doctors, certification. And really, we're not looking for more regulation. So this is a discussion. This is not a mandate or anything like this. This is sort of something. So here we are, and this is what I've kind of come up with. And I'd love to have some dialogue, whether that be online or tonight over supper. But you guys can think through this or email me. And Glenn and I have been thinking through this. Steve Anderson's had some input, and we've just been thinking. So there are two parts of this. Number one, CSC, the level of cataract surgical experience. Get your phone out, so we're going to be checking. But level one, you have no prior cataract experience, but you have microsurgical skills, or you have done cataract surgery, but it's been more than 2 years since you've done previous surgery. So that's your level one in terms of your cataract surgical experience. Number two, level two, the poll's not up yet. So level two, the phaco, you've done 1 to 100 cases, or less than 50 cases in the last 2 years. So we're looking for doctors who are low volume, obviously, in this classification as well. Level three, you've done between 100 and 1,000 cases. And level four, your phaco or other cataract experience greater than 1,000 cases. So think of what your level is, 1, 2, 3, 4, and we'll go ahead and put your level up there as far as your cataract surgeries, and we'll see where we're at. Looks like in our particular group, we're in our, doesn't look like we have many residents answering this, or if they are, they've done over 100 cases already. And it looks like we have pretty active surgeons because A and B have clauses for people who are not active in their surgery. So this is a good level. So we're level 3 and level 4 on our CSE so far. Has everybody had a chance to answer that? All right. So number 2, this is the second part. It's the last part of it. Your level of MSICS experience, ME. So we had CSE, cataract surgical, and this is ME. Level 1, you're prepped. You've done the cognitive. You've come to the course. You did the wet lab. You watched videos. You watched YouTube. You went to a live surgical course. That's level 1. Level 2, you've done 25 or less surgeries by yourself or partly with help or backup within 2-year time frame. If you haven't, if it's stretching over that, you go back to level 1. Level 3, you're between 25 and 100 MSICS as a primary surgeon and at least 25 cases per year. So there's a retention of knowledge here that we're trying to throw into the classification. Level 4, you're between 100 and 300 cases and you're comfortable on your own without backup. Level 5, you've done more than 300 MSICS and you've actually taught MSICS to experienced phacosurgeons more than 25 cases. And I don't have anything about outcomes here, but we have level 5 is you've taught an experienced phacosurgeon. And level 6 is you perform more than 300 cases in the previous 18 months, and you've taught residents or national surgeons more than 25 cases. So that's level 6. So think of what level you are right now, because we're going to text that in. Level 1, 2, 3, 4, 5, or 6. And then go ahead and put your level in there. Now remember what you were for the CSE, and remember what you are here, because those two scores are going to be added together. So why don't you add your scores together, level 1, 2, 3, or 4 for the first, and level 1, 2, 3, 4, 5, 6 for the second. Has everybody had a chance to enter this? And your combined MSICS competency score is adding those two together with 1 to 3, meaning you're a novice. 4 to 5, your beginner MSICS competency, and 6 to 7, which doesn't sound like beginner, is advanced beginner MSICS competency. 8 and 9 is high, and 10 is a full MSICS trainer. So you ready for your combined? Go ahead and put your combined MSICS score in there. For some reason my texting's not working. All right, has everybody got it? So we have some 2, 3, 4, 5, 6, and 1 10 maybe, or a couple 10s, I don't know. We can look at the absolute numbers here shortly. For some reason my texting's not working. All right, and then let's do this. This is the same level. Put your level in, but I've combined them into novice, beginner. So put your level in again. Okay, very good. So it looks like the majority of us are beginner competency, 4 to 5s. And so, how is this helpful? Well, I think what we want to just look at is some of the examples. So here's our first surgeon who is an experienced and he's watched videos only. He's really a beginning competency. And then here's partially retired successful surgeon, but he hasn't done any surgery in 3+ years, and he's on his first mission trip having watched 1 video and gone to 1 course. So what level is he? He's actually a 3 because he's not an active surgeon, but he's had a successful career. But it's trying to set expectations for both those that are going with him, and you go, oh, we're in good shape. We got this guy. He's been an ophthalmologist for 35 years, but yet he's not really done this type of surgery. That's sort of what we're sort of trying to wrap our minds around. And then you've never done MSICS, and you're on your first 2 years of practice. You accompany your experienced phacosurgeon colleague who's done 50 MSICS in the past, but less than 20 a year currently. So I guess that is 6 for your phacosurgeon. So anyhow, the implications of this is really thinking about your ideal teaching situations for your level. And you think about, you know, you're at this level, and so who are you traveling with? Who's training you, or who are you going with? And what's their teaching situation? Do they have a situation set up that's built for you? So if you're in a beginner level training, are they putting you on a scope on your own, and they're over here on this other bed, and that's the expectation, and there's a high volume of patients to be done? Or is it different? Is it a dedicated one-on-one, one bed, 2 surgeons? Is the teacher not responsible for volume of cases? This is for the trainee to think about who's going to be training you and what situation are you getting yourself into. Do you have a teacher who's dedicated to the level that you're at to help? Do we have an expectation that's reasonable? 4 to 8 cases per day for several days in a row that can give you some time, and that we're not talking about, okay, you expect to do 2 and then 8 and then 10 and then 15. And is a teaching microscope available? Do we have video? Do we have binocular so someone can be watching, or you can be watching someone else? And then are you going with a level 8 to 10 teacher? So these are some of the paradigms that I'm throwing out as just suggestions and thoughts, and I'd love to have feedback on this. Now, what I get excited about is going, this is just about the training, but really, ultimately, it's about outcomes for all of us. And cataract outcome monitoring has been out there. The WHO established guidelines many years ago. Most mission surgeons really only have a vague idea of the longer term outcomes. We say, hey, we went down, successful, everybody did great. Or only one patient, but we think everybody did great. And so really, is that where we're at in 2017? Is that adequate to come back from a place and say, we actually have no clue what people, did we return people to good seeing vision? And I think as responsible ophthalmologists, and certainly as Christians, for those of us that are Christian, and really any humanitarian ophthalmologist, we have a responsibility to making sure that our outcomes are as we would expect for our patients around in our own clinic. Nathan Congdon, who's an Orbis-related doctor and has worked in China for many years, has just developed the Boost app. And then I'm going to tell a little bit about the Help Me See Reach app. So basically the precog study was assessing cataract outcomes. It was looking at basically one-day visual acuity as being predictive. You guys don't have an image? Let's try it again here. You get it? Okay, sorry. Thank you. So it was looking at one-day early visual acuity as being predictive of late results. Now, it's an interesting study that you should look at, but here's the study. They got 90% follow-up and many home visits. Most of it, a lot of it was done in China, but they found that visual acuity immediately after surgery was highly predictive of final vision. And so they're using that as part of the basis for this Boost. So Boost is the name of the software, and it's going to be available on Android and I believe Apple, I'm not sure about Apple, very soon. So it's in its final stages, and we've been working on this for about 2 years. This tool is going to get in the hands, and they wanted it to be as fun as Angry Birds, that was their goal. So they wanted it to be a fun thing to use. And so it's an app on the phone, and so here's a picture of the app. With the simple settings, and basically what you're putting in is your pre-op vision and your post-op one-day vision. There's not a lot of things and a couple things about the surgery, and that's what Boost is all about. And then looking at cases that have poor post-op vision, you're looking at pushing them in 3 categories: surgical complications, bad case selection, or refractive error as being the reason for poor vision. And that's what they'll give specific suggestions and measures. Now, truthfully, I think as I've talked to Nathan, a lot of this is really geared towards surgeons in China and surgeons in Africa. as a U.S. surgeon, I go, I want more data than that, really. But this is really, you know, done after the science of this particular article. And so IAPB and WHO are together with this, and they had a grant from Standard Chartered Bank to do it. So anyhow, it's cloud-based and it's password protected, and you can actually decide who can see your data. So when you're on it, you get to determine who's doing that. And so basically, they've worked with Asia, Africa, and Latin America and Pacific, and they're doing it in multiple languages. And it's being finalized. Actually, one of the programmers is the son of my head partner. So here's the little thing that Vision 2020 and IAPB put out about Boost. So keep your eyes open for Boost. It's something that you may want to try. Now, Help Me See has a Reach app, and a Reach app is basically combined screening, GPS, finding these patients, where are they from and where are they going, getting the pre-op data to the surgery center, and then the part that this is the GPS. They can actually localize finding those patients for a post-op follow-up. But then it sends the data to the surgical monitoring, and the surgeon can put in quite a few different parameters. Now, it's totally different than Boost, because if you look at what kind of information, you got more pre-op, more surgical information, and more post-op information. So obviously the challenge and the balance of getting data is what's too much to collect, what's not enough to collect. Because if it's too much to collect and you don't collect it, you got nothing. And so it's not going to be very helpful. But the whole point of this cloud-based is, especially for mission surgeons who are going somewhere, if you have somebody competent who's following the patient, even if it's a nurse or a tech, they can put the data in and you can actually see what the follow-up is. Truthfully, ophthalmologists, we're pretty bad at doing this stuff. You really want a technician or nurse. I know a cornea specialist in Wisconsin that works with Reinhold Dirksen, and he goes down and, but Reinhold's busy and he's busy, and as surgeons we're busy and we don't have time. So you want to know how your outcomes are. So I think we're going to want to involve the technicians in this. But here you can see, I'll kind of move through this. This is just quickly just showing you that it tells which eye, what your diagnosis, what the pressure was, the corneal lens. This is the pre-op exam, so there's a lot of data here, and it may be too much, really. But then there's intraoperative. You actually put a note. Did you have any complications, any notes about the incision or that? So you actually know what your surgical issues were. And then post-op, they're basically getting a vision, a corneal exam, so is it cloudy or not? And then any post-op complication, there's a checkbox for those. And then a 4-week is pretty much the same. So that is, and so my stance on this is I believe cloud-based outcome monitoring for surgical humanitarian missions is critical in taking our care of the world's blind poor to the highest level of excellence. So I'm very excited about seeing this kind of stuff develop and knowing that it's actually available. Right now, the Reach app is not available for us surgeons, and so I'm sort of trying to interface with Help Me See and let them know how important this app is for those that are already working and doing. And Boost will be available freely for everyone. It's not there's no charge for Boost, and it's close. So the summary is classifying your skill set for cataract surgery, both phaco and MSICS, is helpful in patient care. Finding the best trainer for you, having the right support. My surgeon friend, 59-year-old from New York, that ended up going back after Camp Diego, really all he needed was one thing. He just needed a trainer going with him, recognizing that he's not at the level where if he'd had one person there saying, oh no, well hold on, let's do this to deliver, his complication rate would have been very different and his experience would have been very different. And that's really what this lecture is about. And then second, outcome monitoring is a needed complement